Well, thank you for this opportunity to speak to you. So today I'm going to talk about the prostate. It's a very small organ, but it's kind of a big topic. So what exactly is the prostate? The prostate is a small male reproductive organ that's deep in the pelvis, and its purpose is to make seminal fluid. So seminal fluid is the fluid that the sperm swim in. And the seminal fluid is stored in the seminal vesicles, which is right here. And then when a man has sex, an orgasm is ejaculated out. A couple things happen to the prostate as we age. Number one is that you can develop prostate cancer, and we'll talk more about that later. The second thing that can occur is that you can get BPH. BPH is benign prostatic hyperplasia. And this is when the prostate gets bigger as we get older. We don't really understand 100% why the prostate gets bigger, but it has something to do with the hormone changes in our body as a man ages. And it also could be running in the family too. So if your family members all have large prostates, probably likely you'll have one also. So in order to treat prostate problems, we can do non-medical and medical treatment. So some of the non-medical treatment would be supplements. And here is Larry King, and he's trying to sell some of his products. And most of it is saw palmetto. Saw palmetto is a berry that's from a bush that's in the southeast part of the United States. And the Indians in the past used to take that berry and they would boil it and make tea, and they treat their BPH symptoms. So it has some kind of mild estrogenic effect. The other kind of treatment that you could do would be lifestyle changes, and mostly that means drinking less fluid at night. So patients could have nocturia. Nocturia means getting up to go to the bathroom at night, and it could be very bothersome for the patient. So one way to handle that is you can try to drink less at night. So after dinner, don't drink any fluids. And also what you drink is important too. So less alcohol, less caffeinated drinks, so less soda, coffee, tea, etc. But if you fail that and you have moderate BPH symptoms, you can have medical therapy. Medical therapy is different kind of medications that we use, basically 3 different types. We have alpha blockers, 5-alpha reductase inhibitors, and tadalafil. So 5-alpha alpha blockers, such as tamsulosin, silodosin, terazosin, doxazosin, are medications that will cause the smooth muscle around the prostate and the bladder neck to relax. And it originally was used for blood pressure, but we also found out that it works well for symptoms of BPH. Some of the side effects of this medication would be low blood pressure or dizziness. So these newer medications like tamsulosin, silodosin are actually engineered to be more selective for the prostate than the blood vessels, so you have less of that side effect. 5-alpha reductase inhibitors, these are medications like finasteride and dutasteride, and basically they shrink your prostate by about 30%. So there is something called dihydrotestosterone. This is the testosterone that causes BPH and also male pattern baldness. And 5-alpha reductase inhibitors prevent the production of the DHT, or the dihydrotestosterone. The side effects of this medication would be erectile dysfunction. But one of the warnings about this medication is that it has been associated with developing a high-grade prostate cancer. So there is a black box warning about this medication. Most urologists don't really believe that. We follow these patients for a long time, and none of them have really acted like they have a high-grade cancer. So we're not really sure why they have this phenomena, or even if it's true. Actually, this medication has been shown to decrease the incidence of prostate cancer by 30% in general. But there is that black box warning about the medication. And then we have tadalafil. Tadalafil is a erection medication that when the patients were using it, they found that they actually urinated better. And so it was studied, and it's true. It seems to be only unique for tadalafil, and so there's a daily medication for this. But if you fail medical therapy, then we have to go to surgical therapy. And so the gold standard is the TURP, or the transurethral resection of the prostate. So here we have a picture of the resectoscope, and you see on the resectoscope they have this wire, this loop, and it's hooked up to electricity. And so this is a hot wire, and basically we take slivers of the prostate to open up the middle of the prostate. So here you see a picture of the prostate, and it's enlarged, and you can see that the lumen through the prostate is very tight. And with a TURP, you would take slivers of the prostate until you get something like this. And so you can see it's nice and wide open, and you should be able to urinate pretty well. And so this has the best long-term results of all the procedures that we use. But men do fear it because it does have a high morbidity and complication rate. It takes a long time for a person to get over the TURP symptoms. So they have bleeding, they have dysuria, which means it burns when they urinate, they have frequency, urgency, and it takes a while for it to go away, mostly because the mucosal lining inside is all gone. It takes about 3 months for the mucosal lining to grow back, and that's why it takes so long to get better. So we have other kind of treatments that we are doing, and one of them is the laser prostatectomy. So we have different kind of lasers. One is used for enucleation. So if you can imagine, the prostate kind of looks like an orange. So you have the capsule, which is like the rind of the orange, and then you have the adenoma, or the meat of the prostate, which is kind of like the pulp. And the pulp is causing the blockage. So this laser acts like a hot knife, a bloodless hot knife, and we cut the adenoma away from the capsule, push it into the bladder, and then we have something called a morcellator, which we break up and shred the pieces to very small pieces, and then we can actually suction them out. The advantage of this surgery is that it has less bleeding, the recovery is shorter, it has a very high success rate. It is actually very good for people who have large prostates. They still have the dysuria because there's no mucosal lining, and sometimes it's not good enough and they have to have other procedures done. And then here we have another type of laser. This is called a photoselective vaporization. This is where we use a side fire laser to vaporize the prostatic tissue. Again, the same advantages, less bleeding, shorter recovery, high success rate. And it still has the same disadvantages with the burning of the urination, and sometimes it's not quite good enough. Some of the newer procedures that we're doing that are minimally invasive, one of them is the prostatic urethral lift. And this is a mechanical way to open up the prostatic urethra. So we have these small nitinol clips here, which actually will squeeze the prostate tissue together, opening up the donut hole. So here we see the scope going in. It will release one end of the implant. and the nitinol clip will anchor on the capsule of the prostate. Then you squeeze the tissue together and you release the other clip. And you do this in different parts of the prostate, which will open up the prostatic urethra. This is very easy to do. You can do it in the office or in a small surgery center. It's very fast. There's very little dysuria or frequency, mostly because the mucosal lining is still intact. So this is not removed like in the other procedures that you saw earlier. It's durable. It's supposed to last up to 10 years, at least. Another treatment that we're doing that is called water vapor treatment. And this is where we use steam to shrink the prostate. So a catheter is introduced into the prostatic urethra. A small needle comes out and gives you a 9-second steam treatment. And this steam travels between the cells. And what it will do is when the steam becomes water, it releases a lot of energy. And that causes the prostatic tissue to shrink or shrivel down. So it takes about 3 months for the prostate to get smaller. And you can see that now the prostatic urethra is nice and open. And this has a high success rate, very easy to do. You can do it in the office or at a surgery care center. And finally, we have prostatic artery embolization. And this is where we actually do a procedure as opposed to doing a surgery. So this is actually done by interventional radiologists. And what they do is they send a small catheter down the blood vessel and they go to the artery of the prostate. And they release these microparticles. And the microparticles will actually block the blood flow to the prostate. And then this will cause the prostate tissue to shrink down in size. So it works really well for people who have large prostates. It has a good success rate. It preserves sexual function. What that means is that when you have orgasm, you have forward ejaculation. Retrograde ejaculation means that the semen will actually go into the bladder because the bladder neck is open. But in this procedure, and also with the prostatic urethral lift and the steam treatment, the bladder neck stays closed, so you don't have retrograde ejaculation. So that was BPH in a very, very quick manner. So we're going to shift gears now. The second thing that occurs with the prostate as men age can be prostate cancer. And this is the most common cancer in men. So about 1 out of 6 men are going to develop prostate cancer in their life. So kind of like Dr. Kagihara with breast cancer. It's very common. It's the second most common cancer death in men. And there are certain risk factors. There's genetic risk factors. If you have a family history of prostate cancer or a family history of breast cancer, you may have some gene mutations, mostly the BRCA2. And this could cause prostate cancer. And then being African American is also a risk. The way we screen for prostate cancer is getting a blood test. It's called PSA. So PSA is not specific to prostate cancer. It's specific to the prostate. So other things in the prostate, such as an enlarged prostate, inflammation of your prostate, can cause a high PSA, but we use it to actually screen for prostate cancer. And we've been doing this now for 30 years, maybe no longer, maybe 40 to 50 years, but there is some controversy about using PSA for screening for prostate cancer. But if you have a high PSA, normally that leads up to a prostate biopsy. And the way we do a prostate biopsy is using a transrectal ultrasound. So this ultrasound is put into the rectum or the ocole. We can see the prostate. And then we take needle samples of the prostate. And usually we take about 12 samples. What's unique about this is that if you think about it, prostate cancer is probably the only organ in which we take random samples of the tissue to try to diagnose cancer. So if you have something in the liver, you take a sample of that liver mass or the lung mass or the pancreatic mass. You don't do random samples of the whole organ, but we really have a hard time seeing cancer in the prostate with the imaging that we have, and so we have to do it this way. And that's part of the problem of PSA-based prostate cancer screening. So there's an organization called the USPS Task Force. And their job is to look at the way we screen all kinds of cancers and then to evaluate and to make decisions about how we should screen for any kind of cancer, including prostate cancer. And in 2012, they actually gave PSA-based prostate cancer screening a D recommendation, saying that we shouldn't do it anymore. The reason why they said that was, number one, just like we said before, PSA is not cancer specific, it's prostate specific. So if you have a PSA that's about 10 and you got a biopsy, there's only about a 1 in 4 chance that you have cancer, meaning 75% of the people are getting these biopsies unnecessarily. And the biopsy is associated with pain and bleeding, possible infection. The second reason is prostate cancer tends to be slow growing. So most of the prostate cancers grow slowly. Most men will not die from their prostate cancer, they'll die of old age. And so when you do PSA-based screening, you tend to over-detect prostate cancer, and then you tend to over-treat. And when you over-treat, sometimes these men who may have never have any problems from their prostate cancer will have complications from the treatment. And so because of that, we got a grade D, and people began to not screen. But an interesting thing happened. We began to see metastatic prostate cancer. We haven't seen this for like 40 years, but suddenly men were dying from prostate cancer. And it kind of makes sense in retrospect, because some people will have prostate cancer that is slow growing and never bother them, but there are going to be guys who have the high grade, fast growing prostate cancer, and if not caught early, the cancer will metastasize and cause a lot of problems for these patients. And so that's what we saw. And as a result, the USPS task force had to reverse their recommendation. They gave us a grade C, which means that all men should have a discussion with their physician about the pros and cons of PSA screening and then make an individual decision about whether or not they want to have it done. But because of this, though, this has led to us trying to be better in our screening. And so we try to be a little bit more intelligent in how we screen, and we use other tools besides the PSA. So PSA still is the main thing. If you have a high PSA, we can get something called biomarkers. And biomarkers could either be blood or urine or tissue markers. So we have the PCA3, which is a urine test, a 4K, which is a blood test, and this epigenetic is a tissue test, and these supplement PSA. So if you have a high PSA, you might get one of these tests done. If they say you have a low risk for prostate cancer, you're done. We just follow you. If you say you have a high risk, then that will lead to a biopsy. The other way we try to improve our screening and detection is the prostate MRI. So in the past, we had MRIs of the prostate, and we could see lesions in the prostate, but we really didn't know what it meant. It wasn't until we had something called multi-parametric MRIs that we were able to take advantage of using this imaging. So here is a lesion seen on MRI, but we don't really know what that is. But we take advantage of the multi-parametrics. So here is a DWI, diffusion of water index. We know that prostate tissue is more dense than regular prostate tissue. So water diffuses slower through the prostate cancer tissue. And we take advantage of that property. So we can see that over here, the water is moving slower, migrating slower, and it lights up. This right here is a contrast enhancement. We also know that prostate cancer has more blood vessels. And so it takes up more of the contrast. So we take advantage of that too. And so these properties will help us figure out or not whether someone's high risk for cancer. So we have what they call the PIRAS score, the prostate imaging, radiology, and data system score. This is graded from 1 to 5. If you have a PIRAS 1, probably don't have cancer. If you have PIRAS 5, there's a high chance you have prostate cancer. So this helps us to be a little bit more accurate in trying to screen for prostate cancer. The other advantage of the MRI is that we can use that MRI to help us do the biopsy. So there's something called a fusion biopsy. We still use the ultrasound machine, and it's done almost, looks like identical to the way we showed it earlier in the picture. But this ultrasound machine can fuse the MRI picture to it with computer software. So when we are looking at the prostate, we can also see the MRI picture that's superimposed on it. When we move the ultrasound machine probe, the MRI picture moves with it. And so we can actually outline the lesion, and now it's a matter of aiming for that lesion. So before I told you that, we used to do just random biopsies of the prostate because we couldn't see anything, but now we can actually aim for something. And so because of this, our detection rate has greatly improved. But if we find that you have cancer, the next step is to do grade and staging. So grading means we're trying to figure out if you have high-grade cancer, low-grade cancer. It's looking at the quality of the cancer. So a low-grade or well-differentiated cancer grows very slowly. A high-grade cancer grows very quickly. And we used to do something called the Gleason score. So the Gleason score was very unique to prostate cancer. And we looked at the slides, and we looked at the histopathology picture and the pattern, and we gave it a grade. And we did it twice. And then you got the Gleason score. So the Gleason score, the highest it could be is 10. And we've done this for 50, 60 years. However, it's very different than how you grade other kind of cancers. So like breast cancer, liver cancer, it's usually graded 1 to 5, 1 to 4. So we're trying to change the way we grade prostate cancer so it's very similar. So we have group grade 1 through 5. It correlates with the Gleason score. And so maybe nowadays, if you see the urologist, he'd tell you, you have a group grade 4, group grade 5 cancer, as opposed to saying you have a Gleason cancer. The next thing is staging. So we want to see the quantity of cancer, did it spread or not? So we use different kind of imaging to help us figure that out. CAT scans, bone scans, MRI. We also use this new PET scan called the PSMA PET scan. And this is something really nice. It just came out about a few years ago. But we are able to determine if you are early stage 1 or 2, meaning that the cancer is contained within the prostate, or you're a stage 4, where it's metastatic throughout the body. And this will help determine how we're going to treat you. So if you have early prostate cancer, localized prostate cancer. These are the kind of treatments we use. And then if you have advanced prostate cancer, a totally different set of different choices. So one choice for localized prostate cancer is active surveillance. And that's based on the fact that prostate cancer in many men is slow growing, that you'll die of old age. So instead of you having a surgery where you could have different kind of side effects, we would just follow you. That means getting PSAs, it means getting an MRI, it means getting a biopsy once in a while. But hopefully the cancer will not progress and you'll just live a long life and not have any side effects from any kind of treatment. Not everyone will be successful. Some people, the cancer will advance. We try to catch it early so we can still treat it with some kind of treatment. But active surveillance is a very attractive way of monitoring prostate cancer for many men. But if you do need treatment, one treatment is surgery, and that surgery is the radical prostatectomy. And we do the radical prostatectomy now mostly in a robotic manner. So we have the robotic-assisted laparoscopic radical prostatectomy. It's minimally invasive. People recover very quickly from this surgery. You see here that you have the robot here, and the robot has a camera, which is a three-dimensional camera, and you have three other robot arms. This is the tower. This is the brains of the robot. And then you have the console. So the surgeon sits here, he looks through here, and he can see through this camera, and then he can control these arms. Radical prostatectomy, the main side effects are urinary incontinence. Urinary incontinence, you leak urine when you cough, you laugh. The prostate is actually very important for continence. Fortunately, most men won't have long-term urinary incontinence. It usually lasts 3 months to up to maybe a year. And a very small percentage of men will have long-term incontinence. Then there's erectile dysfunction, losing your erections. So the nerves that innervate the penis for erections actually hug the prostate, and so these nerves can get injured during the surgery. So here we have a video of the robot. So you're looking through the console, and you can see in a three-dimensional way these arms. And these robot arms are hinged. They're like little wrists. So it's like little hands in the body doing the surgery. So here you can see the nerves that innervate the penis, bladder, prostate, urethra to the penis. So we unattach the bladder to the prostate. Now we're pushing the nerves away from the prostate, and we'll detach the prostate from the urethra. Take out the prostate. Sew the urethra back to the bladder neck. It makes it look real easy. The other big treatment for prostate cancer is radiotherapy. So radiotherapy is using high-dose X-ray beams to kill cancer cells. So we have different ways of doing it, external beam and different kind of brachytherapy. External beam is when the machine is outside your body. And so wherever the machine is focused to, in this case the prostate, it will treat that tissue and it will kill the cancer cells. This treatment, you usually get a baby dose in maybe about 5 minutes, but you have to get a lot of treatments. So you have to get about 38 treatments, Monday through Friday, so about 7 weeks to 8 weeks. Side effects are frequency, urgency, urgent incontinence. There's a little bit of radiation scattered to the surrounding tissues, including the bladder, around the rectum. So sometimes you get rectal bleeding, bladder bleeding. And then unfortunately also the nerves are very close to the prostate, so they'll get affected too. So you can get some erectile dysfunction. Brachytherapy, the traditional way is what we call seeds. And so we put these seeds into the prostate, and you get the radiation from within. So you don't have to come to the radiation or cancer center every day. Once you get the treatment, then the radiation seeds are in your body, and they'll give you your treatment within, and then so it's much more convenient. It really depends on what kind of prostate cancer you have. Sometimes you have to supplement it with external beam, but maybe a shorter course. And then high-dose brachytherapy is where we use these tubes we put into your prostate, and you stay in the hospital 1 day or 2 days, and you get high-dose radiation, and then take the tubes out. Other treatments are focal therapy. Focal therapy is very attractive because it would only treat the area that has the cancer. So in theory, then, the rest of the prostate will be spared, and so hopefully there'll be less side effects, and they'll be less severe. It's minimally invasive, and it's becoming more and more popular. The problem with this treatment is that prostate cancer tends to be multifocal. It can be in different parts of the prostate. And sometimes, our problem is that we have a hard time diagnosing exactly where it is. So we get a little nervous that we might miss one area of the prostate with focal therapy, and then as a result, the cancer is still there. But this is becoming more and more popular, and people are doing it more often. And then we have cryoablation. Cryoablation is freezing the prostate. So if you freeze the prostate, then you can kill the cancer cells. And this is another minimally invasive way of doing it. Not quite as popular as the other therapies. Now, if you have advanced prostate cancer, that usually means it's metastatic, it's spread through the body, it's non-curable. But it's very treatable, it's very manageable. And the main treatment was hormonal deprivation or hormonal treatment. In the 1940s, there's a urologist named Charles Huggins, and he got a Nobel Peace Prize because he found out that the prostate tissue depends on testosterone. So prostate tissue and prostate cancer needs testosterone to grow. And so if you can get rid of testosterone, the male hormone in your body, the cancer will stop growing, and actually it will regress. So in the past, the best way to do this was castration, bilateral orchiectomy. There are other ways of doing hormonal therapy. So we can do estrogen treatment. We don't really do that too much anymore because the side effects of estrogen treatment are severe. People have had strokes and heart attacks. So estrogen treatment has gone by the wayside. But we do LH, RH agonists, and these are some of the drugs that we use. So if you look at this picture here, the testicles make the testosterone. There is something in the brain called the pituitary gland, which sends this hormone called LH, and LH tells the testicles to make testosterone. So these medications will block this pathway so that the testicle actually will stop making testosterone because there's no signal for it to do it. And that's like a medical castration. We also have the adrenal glands. The adrenal glands make a very, very small amount of androgen. And so that could cause sending a signal down to the testicles to make testosterone. So we can actually block that. So these are anti-androgens, flutamide, lutamide, bicalutamide, and these block the pathway from the adrenal gland to the testicles. So if you do both of these, that's called complete androgen blockade. And this is what we used to do even today, but in 2007, this is how we would treat prostate cancer. Unfortunately, metastatic prostate cancer will tend to become castrate resistant maybe 5 years after the beginning of treatment. And then when that happens, we didn't have anything that could help you after that. So, that was unfortunate. But fast forward to 2023, we have a lot of different kind of treatments now. Hormonal deprivation is still the mainstay, but we can supplement it with other kind of treatments. So we have these new LH, RH antagonists, which can treat block the pituitary gland, just like the other medication that we used previously, but in a different manner. What's nice about, we have a new medication here, Relugolix, which is actually a pill. So the rest of these are all injections, but we can use a pill that will help us to control the hormones, and you don't have to get an injection. We found out that chemotherapy is helpful. There's one medication, docetaxel, which if you give it with the hormone therapy, the survival is much longer. It's really meant for men who have advanced prostate cancer. And then we have immunotherapy. This is a very exciting new way of treating cancer. Unfortunately, immunotherapy and prostate vaccines, although they've been developed, they haven't really worked that well. But this is a new avenue to treat prostate cancer and all kinds of cancers. And so it's exciting. There's a lot of exciting research going on about this. If you have advanced prostate cancer that goes to the bone and causing bone pain, we have medication that will treat that. So strontium and radium-223, they will actually prevent bone pain and actually will shrink the tumor at the bone. These are second-generation non-steroidal anti-androgens. And these have been developed over the last less than 10 years. And they are fantastic drugs. They supplement the traditional hormonal therapy. But when you just do traditional hormonal therapy, a lot of times, again, becomes what they call castrate resistant. The cancer starts to grow even though there's no testosterone. And we found that these new drugs can even block the cancer at a different level and be much more effective. So men now are living much longer. There are men who have metastatic prostate cancer who are out 10, 15 years now and still doing great. And that was unheard of, maybe 15 years ago. And there are some new things out there. HARB inhibitors. If you have certain genetic mutations in your prostate cancer, HARB inhibitors will actually really work well for these patients. Lutetium is something new and it's exciting. Lutetium is usually attached to a PSMA antibody. So I think I mentioned to you before, there's a PSMA PET scan. And PSMA is an antibody that if you inject it into the body, it will go directly to the cancer cells. If you attach lutetium to it, the lutetium will travel to the cancer cell and actually kill the cancer cell. So in some ways it's a smart bomb. And so I had one patient who had metastatic prostate cancer, wasn't doing well at all. He had this done as part of a study. Everything melted away. His PSA is 0, and you can't find any prostate cancer in his body, and he's just doing fantastic. And now it's still about 5 years out from when he got his treatment. So that's the prostate, BPH, and prostate cancer in 40 minutes. Thank you very much.
Thank you, Charles. That was wonderful. A really great overview. I think we'll take questions now.
Yeah, my husband had the prostatic artery embolization recently at the University of Wisconsin, and it's done by an interventional radiologist, and the results were great with no side effects. So I wonder if that procedure is available to folks here in Hawaii. And also, it seems to be pretty difficult to get an appointment with a urologist. So I was curious about the shortage in that area.
So number one, yes, prostatic artery embolization is available in Hawaii. At Queens and at Pali, Momi, we do it. And just like you said, it's very impressive. Some of these patients who have very large prostates and who would have had a TERP and it would have just been misery for them. They probably would have got better in the long run, but just misery for them in the short run. They do really well with PAE. We do have a urology shortage. So it's nationwide. It's really bad in Hawaii. It's really hard to see somebody. I agree with you.
We'll go to some of the online questions. How long can you take tamsulosin and finasteride if you have BPH? Is there any benefit for long-term use?
Yes, there is. So you could probably take that the rest of your life if it's working well for you. One thing about tamsulosin or alpha blockers is that it doesn't prevent the continued enlargement of your prostate. So your prostate will continue to get bigger and bigger, and maybe down the road, these medications may not work so well. Finasteride or 5-alpha reductase, they shrink your prostate. They may have better long-term success. So actually, when you first take both of these pills together, usually there's a combo. A lot of times we give a combo treatment. Maybe the first year, 90% of the work is done by the alpha blocker. But at maybe 2 years, 3 years out, most of the work is done by the 5-alpha reductase. The other thing that's interesting I found out about BPH is that as you age, the BPH will affect your bladder. And so sometimes men are reluctant to have any kind of treatment, any kind of surgical treatment on their prostate, and I can understand that. But what I found was that there is a sweet spot, because if you wait too long, for some men, you'll have irreversible bladder changes, and they, no matter what you do for them, you're not going to help them. They're going to have bad frequency, bad urgency, urge incontinence, urinary retention, and you can't really fix it at some point. It's irreversible. So not every man gets to that point, but if you're able to identify a person who's heading in that direction, even on the medications, sometimes it's better to say, hey, look, maybe you should have this procedure done because, I think in the short run, you're going to be fine, but in the long run, you're going to have a lot of problems, and maybe it might be better to have a surgical therapy.
You didn't speak of proton therapy. What do you ever recommend proton therapy for men?
Yeah, I didn't mention it. So there's some newer things out there, proton therapy, SBRT, which is stereotactic body radiation. And just for lack of time, proton therapy is more accurate than the traditional radiation we use. So you can potentially have less side effects because you would have less radiation scatter. It's a lot more expensive, and there are a few studies out there that say that even though there appears to be, in theory, some benefits to the proton therapy, sometimes clinically is not too different than just the regular standard radiation we use. But you're right, proton therapy is out there, and a lot of people use it.
If the prostate is made smaller through surgery, does that affect its function?
Yes, it can. So you would probably make less seminal fluid. Also, there's what we talked about before was retrograde ejaculation, meaning that when you have orgasm, the fluid goes into your bladder, it doesn't come out forward. But sometimes the treatment that we do will affect the glands of the prostate so that you make less seminal fluid. Fortunately, most men who have BPH are beyond the reproductive age, at least maybe their partner is, so it's not usually a big problem.
At what age do you stop checking for BPH or for cancer?
Well, if you look at the AUA guidelines, 70. In Hawaii, we tend to check longer. I think the guiding principle, number one, is a recommendation, not a mandate. But the guiding principle is that if you have a life expectancy greater than 10 years, probably you should still check. So if you have a gentleman who's 75 and he's playing tennis and he's playing golf and he's taking ukulele lessons and you still check, But if you have a 60-year-old guy and he has bad diabetes and bad heart disease and then you probably would not check anymore because his life expectancy is so short.
Can prostate cancer be prevented with lifestyle behaviors?
Yes and no. So there is a genetic component to prostate cancer, and there's probably an environmental element to it too. So there is actually a very famous study from University of Hawaii, and they looked at the Japanese men from the different generations. So they looked at the Issei men. Their prevalence of prostate cancer was the same as the Japanese men in Japan, which is very low. And then you look at the second generation, the Nisei, the Sansei, the Yonsei. Every generation, the prevalence of prostate cancer increased until it hit the same as a Caucasian on the mainland US. And so there's something in the environment that is causing this change. And most people believe it's diet. And so it's more of a Western diet that probably fuels the prostate cancer. And so the recommendation a lot of times is a Japanese style diet, more fish, less meat, or a Mediterranean diet. And so those are things. Also, they say moderate amount of exercise helps too.
Any more questions from our live audience? I don't see any questions online either.
Okay.
Okay, thank you very much, Charles.